Hi, I'm Shalini Arunogiri, and I'm a psychiatrist, and I'm the chair of the Faculty of Addiction and Psychiatrist at the college.
You've just been at one of the sessions on smoking, which is a big focus here. Could you just outline really what happened there and what the main messages were?
So we're really excited at the conference to be able to host our invited speakers. So the Faculty of Addiction invited Professor Billy Bernowski, who's a psychologist who works at University of Newcastle, and she's a tremendous champion in this field in terms of smoking cessation research in people with mental illness, and has basically dedicated a life of research to being able to understand how we can change the story around helping people with mental illness quit smoking cigarettes. So it's a real pleasure to be able to host her at this conference.
And what was the presentation mostly about?
Yeah, so Billy managed to put together a whole range of evidence on why people who have mental illness, and also people, that includes people with drug and alcohol problems as well, so people with mental illness and drug and alcohol problems might struggle to quit smoking cigarettes. She really made some clear and key points that are really supported by decades of research, that people who can't quit, who've got a mental illness or a drug and alcohol problem, they're not having difficulties quitting because they don't want to quit. I think that is a myth that's often out in the population, that people who can't quit are not doing it because they aren't interested. And I think she did a great job of really showing that decades of literature has really not supported that fact, that people actually do want to quit. And so a lot of the presentation was about how we can actually change that. How can we actually help people quit more effectively?
A big issue, or a couple of issues often come up around that with smoking and mental health. One is that there has been this tradition of saying it's the least we can allow people who are suffering to continue to do. But the other is that a lot of people with mental health issues say, stop focusing on smoking, look at medication, look at other things that are more important. What do you say to that?
Yeah, I think it's really important to get the views of both the people who are struggling to quit, but also the clinicians who are trying to help them, or not help them in some cases, quit smoking, because they're all relevant in trying to understand how we change the whole picture. And I think Billy's work is really unique in that regard, in terms of working in a field around implementation science, of trying to understand how we actually change practice. I think what's relevant there, what's interesting there, is that both for people who work, professionals who work in drug and alcohol services, as well as people who work in mental health services, we come from a place, I suppose, of compassion, of trying to help the individuals in front of us. And I think if people are saying that, I'm really struggling to quit and it's often not my priority right now, I think what clinicians are hearing in that space is, I really want to help you with the thing that you identify as a priority, and I think that's really important. But I think having the long view, as well as, understanding that, medications, certainly we need to look at medications and the impact that might be having on someone's physical health. But having that take-home message and that clear message in our minds as professionals is tobacco is the leading cause of morbidity and mortality in people with mental illness. It's not to diminish the impact of the medication use, not to diminish the impact of drug and alcohol problems per se. But at the end of the day, tobacco use in itself is often what's going to cause both the morbidity in terms of other physical problems, but also what kills many of our patients in the long run. So, even if today is not the right time to be able to quit, it's about having that in the back of everyone's mind, coming back to it from time to time, looking at what interventions a person can look at. But also, I think a really interesting message from Billy's presentation was around harm reduction in this space, and tobacco and harm reduction haven't necessarily always, there hasn't been much of a discussion about that in comparison to some other drugs that are used. And I think there is really a role for harm reduction in people who have mental illnesses who might be struggling to quit. How can we actually try and, in the short term, minimize the risks associated with smoking tobacco and nicotine?
Fantastic. And Shalini, any other takeaways from the conference? You've been here through it all?
Yeah, it's been a packed conference, and I think it's been really great. I think this conference is our biggest conference as college psychiatrists, and what's really great about this conference is being able to see old friends and see old colleagues and catch up with people you might not have seen for years. So that's my biggest takeaway from this conference always. We've always had some great keynotes, and I think this morning's keynote from Sam Harvey from the Black Dog Institute was really great. I think it really shone a spotlight on doctors' mental health and junior doctors, and I'm really glad to see so much work's been done done in the space to support our colleagues.
What was your takeaway from his?
Yeah, I think it's interesting I think there's a little bit of a shift, a change in focusing just on resilience factors alone without understanding what goes on in organizations and in workplaces itself. So I'm really pleased to be able to see that change starting to happen and see trials that are actually starting to recognize that as being factors too.
And what would you like to see at the next Congress? What was missing?
What was missing? That's an interesting question, Marie. I think there's lots of things we'd like to see from a faculty of addiction perspective. I think we also have some other conferences in the drug and alcohol space that also go alongside this. But I think having more and more of a dual diagnosis focus and having more conversation around that. I think as psychiatrists we work a lot across lots of different spaces, and I think as long as we can kind of have this conversation happening, I think that's really exciting.
Fantastic.